Hello everyone, happy evening, a very good evening. I hope and I believe all of you are doing well. A quick note everyone, am I audible and visible everyone? So let's start discussing the question for today. The first question that we have is, in aortic dissection, which finding is characteristic of true lumen as compared to the false lumen? Right, so let's have a look at this one. So aortic dissection is where there is intimal tear in the aorta which happens. Can you tell me what is a very important background history or risk factor that's generally given in a clinical question in aortic dissection? What history is generally given in aortic dissection? Yes, it's a history of hypertension, right? High blood pressure tearing the intima leading to dissection, right? So you have a true lumen and you have a false lumen, right? The intimal tear producing the false lumen. Absolutely right. So, generally what you would see is we have learned in our radiology videos on the PrepLadder app that if you see this beak sign, this is suggestive of a false lumen. The false lumen will have comparatively slow flow, right? So the cobweb formation, thrombus formation is more. So the cobwebs, that is intimal remnants, is going to be more in false lumen, and so is the thrombosis, right? Is this clear with everyone? The false lumen is more crescentic shape like this which you have, okay? And thrombus is more common, cobweb is more common. True lumen will have a dense systolic flow. So look at the options here. It has a beak sign. Remember, beak sign is suggestive of false lumen. It is larger in size and shows delayed contrast opacification. This is true for false lumen. It has a cobweb sign due to the thrombosed vasa vasorum. This is also for false lumen, right? So it is smaller in size and shows early, more intense contrast opacification is true for true lumen. So true lumen is generally smaller and false lumen is the one which is generally larger. The beak sign, the cobweb, the thrombus, all this is more common in the false lumen. Stanford A and Stanford B. A is for AA, ascending aorta. If involved, it is Stanford A, and B is below the ascending aorta when ascending aorta is not involved. A is for ascending aorta, A is for acute management. Surgery is required for, surgical management is required for Stanford type A. Okay, so the answer is going to be D. Going on to the next one, right? What do you think is the answer to this question? Multiple swellings which are there and increasing in size. There are compressible nodules also which are present. Radiograph is given. So what is this? Is it all ears? Is it Maffusi's? See, when the hand x-ray is given, the small bones of the hand, you are thinking of enchondromas. What is all ears and what is Maffusi's? All ears is all E, that is all enchondromas. And Maffusi's, M for M, is a mix of enchondroma plus hemangiomas, right? It has hemangiomas. So Maffusi's will have hemangiomas also. How do you identify hemangiomas? Is by they have those calcific areas, the phleboliths which are present in hemangiomas, the soft tissue nodules which are present, right? So remember that stippled calcification here, you will have enchondromas plus the soft tissue tumors which tell you that there is hemangioma also present. You can see some calcified areas here in the soft tissue suggestive of phleboliths and hemangioma. So this is going to be Maffusi's syndrome. Okay, this is going to be Maffusi's syndrome. Is this clear with everyone? So all ears, the trick is all E's enchondromas. Maffusi's is a mix of enchondromas and hemangiomas. And how do osteochondromas appear? Osteochondroma grows away from the joint. It is this mushroom shaped tumor that you have, that is osteochondroma. Okay, that is osteochondroma. Remember the chondro part, the cartilage part, it has the cartilage cap which is present. Okay, cartilage cap is present in osteochondroma. All right, let's go to the next question here. Yes, what do we have here? This is an asthmatic man who's there. Antibiotics has not improved the symptoms. There is a positive test for aspergillus, elevated serum IgE. So asthma with aspergillus, elevated IgE. You know that IgE elevated. You are thinking of some allergic condition. So allergic bronchopulmonary aspergillosis, ABPA is what we are thinking about. So in ABPA, bronchopulmonary aspergillosis, you know that there are those dense fungal elements and the mucus in the bronchi. So there is going to be central bronchiectasis, very, very important. Remember, ABPA has central bronchiectasis with what appearance? That is finger in glove appearance, or the gloved finger appearance. The bronchi which are there, imagine these are the bronchi dilated and filled with the mucus. So finger in glove sign is what you would have there, right? Why is it not air crescent sign? In air crescent sign, you have a cavity in a lung into which the fungal ball comes and sits in, right? So there's going to be pre-existing history of a cavity like TB, and then the fungal ball comes in, that is aspergilloma. Halo sign is something that you see in angio-invasive aspergillosis. Okay, when it is angio-invasive aspergillosis, you have an infarct surrounded by hemorrhage that gives the halo sign, right? So look at the images here from your RR. We have discussed this. This is the bronchi which are dilated, filled with mucus, finger in glove sign. This is the cavity in the lung where the fungal ball has come in. And then you have the air crescent sign, the air like a crescent which is present, right? You can also see this air crescent sign in the fungal ball here. And this is the halo sign, right? Surrounding the central infarct, surrounding that is that halo, which is seen in angio-invasive aspergillosis, right? Air crescent sign has been asked in one of the recent FMG exam as well. Okay, going on to the next question. Skeletal scintigraphy, because of the pain and there is diffuse increased activity throughout the skeleton, right? And there is absent renal activity. Can someone tell me what is this term called as in the bone scan? When you have bones may diffuse uptake, but the soft tissue uptake, the renal activity is absent. What is this called as? This is also one of the PYQs of your AIIMS exam. This is something called as super scan. Okay, what is this called as? This is called as super scan. Super scan is when in the bones there's a lot of uptake and the kidney is not showing uptake because everything is being taken up by the bones, right? So remember, there are two causes for super scan that you should know. It is because of the metastasis to the bones, the osteoblastic metastasis to the bones, or it is because of metabolic conditions like, let's say, hyperparathyroidism. Okay, hyperparathyroidism. So out of this, which cancer has those osteoblastic bone metastasis? It is prostate cancer, and that is why we will think of prostate cancer here. This is called as super scan, right? There's a lot of uptake in the bones, right? So metastatic condition, metabolic condition is what you should remember here. So look at this. This is where you see the bones, the black areas is the increased uptake that you see. And comparatively, the kidneys here do not show the uptake. This is what is called as super scan. Okay, this is what is called as super scan. Going to the next question. Plain radiograph showing subperiosteal erosion along the radial aspect of the middle phalanges. This is classical of which condition? Subperiosteal erosion, subperiosteal resorption is seen with hyperparathyroidism. Okay, hyperparathyroidism, classically starting on radial aspect of middle phalanx of the fingers, and that is why the first x-ray that you generally take in hyperparathyroidism is hand x-ray. Okay, so look at this one. Look at the concavity, the fuzzy margins of the radial aspect of the middle phalanx. This is hyperparathyroid. And can someone tell me what are these lytic bone lesions in hyperparathyroidism called as? What are these lytic bone lesions called as? Brown tumors, which are not actually, tumors. This is the lysis caused by the resorption and then the hemosiderin coming in. Remember, this is brown tumor. In the case of hyperparathyroidism, Shruti is what we are talking about. So this is brown tumor. What is the appearance of the skull in hyperparathyroidism? Remember, parathyroid, P for P. Pepper skull, pepper pot skull. It is called as salt and pepper skull or pepper pot skull. Right? Salt and pepper skull or pepper pot skull. And remember, for hyperparathyroidism, what scintigraphy, what nuclear scan do we do? Very, very important. It is cystamebi scan. Okay, very, very important. What scan do we do? Is cystamebi scan is done for parathyroid adenoma. Correct. Next one, identify this angiogram. Is it celiac, superior mesenteric, inferior mesenteric, or femoral? What artery angiogram is this? How do you identify this? Okay, so let's first try to have a look at the three images and then we will come to that question wala image. Image A, image B and image C. See, from the abdominal aorta, you first have the celiac trunk, then you have superior mesenteric artery, then you have inferior mesenteric artery. Celiac trunk supplies the upper abdominal organs, that is the liver, the stomach and the spleen. So you have hepatic artery coming in, you have splenic artery coming in. So if you look at the image C here, a celiac trunk giving the left side wala splenic artery, you have the common hepatic artery, then giving the left gastric artery, right? So one going to the right, one going to the left, one going in the middle. So it is supplying the liver, the stomach and the spleen. That is how you identify celiac. ये upper side में ऐसे इसकी branches जाएगी. Coming to SMA and IMA. Now we know that in SMA and IMA, supplying the colon, the right colic, the middle colic comes from the SMA. So if you see a branch coming on the right side, right, it is going to be superior mesenteric artery. If you see that majority of the branches, they are coming on the left side, okay, that is going to be left colic branches vagera. So that is going to be inferior mesenteric artery. Is this clear with everyone? So ileocolic artery will then give the appendix wala artery, the right colic artery, right? So you will have the right colic, the middle colic artery. Branches on the right is SMA, branches on the left is IMA. So this is going to be SMA, this is going to be IMA, and this is going to be celiac. Now let's have a look at the image given here. Okay, so what are you seeing in this image here? This artery is not just giving the branches above. You can see that it is coming down, right? So this is not celiac. You can see the branch coming on the right side, right? You can see this branch coming on the right side. So this is going to be superior mesenteric artery angiogram. The few branches that you see coming on the left side, those are the small, the jejunal and the ileal branches that you are seeing. This is going to be SMA angiogram, which gives the right-sided branches. Okay, celiac will go upwards. This is going like downwards. Okay, so this is going to be SMA angiogram. This has been asked in one of the previous, 5 years back or so in the NEET PG exam. This has been asked. Okay, so this is important. Going to the next one. Right, of course, you know the diagnosis here. This is very, very important image. Here you can see the black air under diaphragm, the black air under diaphragm. So what is the diagnosis here? This is air is pneumo. In the abdomen, this is pneumoperitoneum, which occurs because of perforation of hollow viscous organ. So out of this, which will cannot cause such presentation? What perforation? Of course, gallbladder perforation, because gallbladder does not have air. Gallbladder has bile. Okay, a hollow viscous organ is what causes pneumoperitoneum. So GIT wala part, stomach, duodenum, ileum will cause this pneumoperitoneum and not gallbladder perforation. Can you tell me what lateral decubitus X-ray do we take in pneumoperitoneum? If you have a patient of perforation, pneumoperitoneum, what lateral decubitus X-ray will you take? Left lateral decubitus or a right lateral decubitus? It's always going to be left lateral decubitus X-ray with what beam of X-ray? Horizontal beam or vertical beam? So when the patient is left lateral decubitus, in lateral decubitus, it's always the horizontal beam of X-ray. Okay, it is going to be horizontal beam of X-ray. Why do we take left lateral decubitus? So that any air in the lesser sac will go through the epiploic foramen. It will come towards the liver, the upper side, the right side. So remember that it is left lateral decubitus with horizontal beam of X-ray. Very, very important. Okay, that's absolutely important. Going to next one. What is the contrast used in barium enema? Of course, it's not lead. What barium? It is barium sulfate, not barium sulfide or barium carbonate. Remember, it is barium sulfate, which is inert, non-toxic. So barium sulfate is what is used as a contrast in barium studies. Remember, barium studies are contraindicated in cases of perforation, right? Because it is water insoluble dye. So if it goes out from the perforation site, it will cause peritonitis, right? So remember, in that case, what do we use is water soluble dye, which is what dye? Iodinated contrast. Okay, in that case, we use water soluble iodinated contrast. Okay, next one. What is most useful in differentiating a dilated heart and pericardial effusion? Very good. See, wherever there is effusion, there is fluid that you want to look at. For fluid, the most sensitive investigation. What is the most sensitive investigation for fluid? It is ultrasound, right? Because fluid is, even minimal fluid is very well picked up on ultrasound. So that is why it's going to be ultrasound. What is ultrasound of heart called as? Echocardiography. Right, so if this is the heart, you would see the black fluid surrounding the heart if it is effusion. If it is the heart dilated, you will see the heart itself dilated. So for pericardial effusion, it is UST echocardiography which is done. Can you tell me the sign seen on lateral X-ray in pericardial effusion? Anyone, what sign do you see on lateral X-ray in pericardial effusion? I'm specifically asking about the lateral X-ray. In the frontal radiograph, you have that flask-shaped heart, money bag heart, right? So between the two layers of fat surrounding the heart, there is fluid accumulating, the white fluid accumulating. That is something called as Oreo cookie sign, right? The Oreo cookie sign. So you have the two black layers, and then in between that, you have the white fluid which is accumulating. The Oreo cookie sign is what you see on lateral X-ray. Next one. Obliteration of left heart border is suggestive of what lobe pathology? Tell me, this question is based on what sign? What sign are we talking about here? So this is the loss of the border sign. So loss of border sign, that is called as Silhouette sign. So if it is the right heart border gone, it is right middle lobe. If it is the left heart border gone, it is, you do not have the left middle lobe, it is lingular, right? So it is going to be lingular pathology. If it is the lower lobe lesion, it will obscure the diaphragm. Okay. So remember that it is lingular pathology, loss of border sign, Silhouette sign. If it is the right heart border which is not clearly seen, it is right middle lobe. If it is the left heart border not clearly seen, it is the lingular lobe. Okay, it is the lingular lobe. Now this image, tell me whether this is right middle lobe pneumonia or is it right pleural effusion? This image, is it the right pleural effusion or is it right middle lobe pneumonia? Why is it not pleural effusion? Because you are seeing that the CP angle is not blunted. With pleural effusion, the first thing you see on X-ray is the blunting of the CP angle, right? One of the NEET PG exam questions. So because it is, there's no blunting here, this is not the pleural effusion. Next one, what is the investigation of choice for spinal cord tumor? See, definitely not plain X-ray. Spinal cord is like a soft tissue, right? Myelography is something we do not do now. So is it CT or is it MR? So remember, in neuroradiology, when you want to see the parenchyma, the brain parenchyma, the spinal cord, MRI is the investigation of choice. Okay, MRI is the investigation of choice because it shows you the spinal cord very well. The spinal cord altered signal intensity, T2 hyperintensity, edema, all of that is well seen on MRI, right? MRI is better for the soft tissue resolution. Okay? So remember that it is MRI, even for posterior fossa, MRI is better, right? Even for posterior fossa, MRI is better. CT is when you would prefer in cases of emergency, like in cases of trauma, that is head injury. In head injury trauma, you will do CT. But if it is traumatic paraplegia, right? This is also one of the previously asked questions. If it is traumatic paraplegia, when I say paraplegia, that means you are suspecting pathology at the level of spinal cord, not the brain. So for traumatic paraplegia, it's going to be MRI. But for head injury, it is going to be CT. Okay? Next, on CT, all of these are seen as hypodense areas, except which of the following? So hypodense, hypo means less, density, less density means how will it appear? It will appear dark. Hyperdense, increased density, matlab it will appear white. What is that? Correct. It is cerebral hemorrhage. Remember, and even in that, it is acute cerebral hemorrhage. Why? Because of the fresh RBCs. The density in that is going to be more. So it appears hyperdense. Okay, so it appears hyperdense. Cerebral edema, there is water. In infarct also, the edema sets in. So the water accumulation is there. The density is decreasing, so it appears hypodense. So remember, Acute brain hemorrhage is what is white, is what is hyperdense. Okay. Right. Edema is water. The brain parenchyma is being replaced by water, which is less dense. So it is hypodense. So look at this one. This is how the hemorrhage appears like. The white area that you see is the hemorrhage, and that too acute hemorrhage. Okay, that too acute hemorrhage. Next one. Where do you see whirlpool sign? See, think logically, even if you have not heard about this sign. Whirlpool means something which is like this, round and round, right? Twisting. So whirlpool is basically round and round, that is twisting. And what is twisting called as? Twisting is called as volvulus. So the answer is going to be midgut volvulus with malrotation, right? This is twisting. Twisting means volvulus. So the vessel twisting, along with that the mesentery twisting, that is what gives the volvulus whirlpool sign. Similarly, you can see this whirlpool sign in testicular torsion as well. So it is volvulus or it is torsion where you see this whirlpool sign. So now tell me that what is the appearance of the duodenum in midgut volvulus in the barium studies? See, when you want to look for the malrotation, the upper GI study, the barium study is a very good investigation. It tells you the location of the bowel loops. So what appearance does the duodenum give? The twisting of the duodenum, that gives the corkscrew appearance of the duodenum. So like you see here, there is this corkscrew appearance of the duodenum. Corkscrew duodenum. And you have here the twisting of the vessel with the mesentery. That is the whirlpool sign. Okay, that's a whirlpool sign. So remember, malrotation predisposes to volvulus. So corkscrew duodenum. We are not talking about corkscrew esophagus, right? Corkscrew esophagus is diffuse esophageal spasm. Corkscrew duodenum is midgut volvulus. Next one. In which condition do you see striate nephrogram? Oh, sorry. The two options have become same here. My bad. Right. It is ARPKD. So striate nephrogram, remember you get in ARPKD, and you have a second which is also acute pyelonephritis. Okay, acute pyelonephritis as well. The difference between ADPKD and ARPKD is in ADPKD you have large cyst in the kidney. Right? So when you do IVP, what appearance does it give? The cysts do not get filled with contrast. They appear as the holes in the kidney filled with contrast. That is called as Swiss cheese nephrogram. Swiss cheese appearance. ARPKD gives the striate or the sun ray appearance. Okay, same thing you see in acute pyelonephritis. With acute pyelonephritis, the kidney becomes large, edematous, compressing the vessels, so there are areas of decreased blood supply, edematous areas, decreased blood supply, you get the striate nephrogram. Similarly, in ARPKD, you get the striate nephrogram. Okay, remember in ADPKD it is Swiss cheese, in ARPKD it is striate. Next one. What do you have here? Shipyard worker. Whenever you see, you start thinking of asbestosis, right? There is pleural calcification also which is given. So obviously this is going to be asbestosis. Shipyard worker, pleural calcification is definitely asbestos exposure. Okay. What sign do you get with the pleural calcification in the X-ray? The holly leaf sign, right? The pleural calcifications seen end phase in the X-ray, they give the holly leaf sign. What is a specific tumor? The pleural tumor, that is mesothelioma. Okay, that is mesothelioma. So let's have a look at this image here. The white. Okay, this is a potential image for your exam. The white that you see here in the X-ray, these are the pleural calcifications, holly leaf sign. Okay. And you can see the white calcifications in the CT as well. The pleural calcifications telling you this is asbestosis. Okay, this is asbestosis. Okay, very important and frequently asked. Next one. What is the earliest radiological sign of pulmonary venous hypertension? See, when there is heart failure which sets in, the first thing, the back pressure goes to the pulmonary vein. So pulmonary venous hypertension, what it does, it makes the vessels prominent, right, against the gravity. So the upper lobe vessels become prominent. Normally what happens, because of the gravity, the lower lobe vessels are prominent, but here because of the back pressure against the gravity, cephalization. That is, the upper lobe vessels become prominent. So what sign does it give here? What sign does it give? You see the upper lobe vessels prominent, hands up sign, or the stag antlers horn sign, right? Or it is also called the inverted mustache sign. Okay, so that is what it gives. It is suggestive of pulmonary venous hypertension. After that is when comes the pulmonary interstitial edema, pulmonary alveolar edema. So when you see the curly B lines, remember B lines are seen at the base, like this short horizontal lines. Those are suggestive of pulmonary interstitial edema. Okay, those are suggestive of pulmonary interstitial edema. So remember, pulmonary venous hypertension is cephalization of the blood flow. Okay, I'll come to bat wing question also we have ahead. In which condition do you see the pruning of the pulmonary arteries? See, what do you mean by pruning? A pruned tree appearance is a tree with peripheral branches cut off. So if these are the lungs with the vascularity, you will see the vessels only here. You are not seeing the vessels in the lateral, the peripheral part. So the peripheral vessels are cut off. So this is what you see. This happens in pulmonary hypertension. Because of the hypoxia, the vessels go into constriction. You do not see the peripheral vessels. So remember, it is pulmonary hypertension. Now, when I say it is pulmonary hypertension, so the pressure in the pulmonary artery is more, right? So what will you see with the main pulmonary artery? The main pulmonary artery is enlarged, right? So in the center, this is the heart. You would see the main pulmonary artery, which is prominent. Okay. What is that appearance called as? Jug handle appearance. Jug handle appearance of the pulmonary artery, right? Correct? How do you identify pulmonary hypertension on CT scan? See, on CT scan, you have superior vena cava, ascending aorta, and pulmonary artery. If the pulmonary artery diameter is more than the aortic diameter, that means the pulmonary artery is more under pressure. So pulmonary artery by ascending aorta ratio more than 1 is suggestive of pulmonary hypertension. That is how on CT we identify pulmonary hypertension. Correct. The pulmonary artery more prominent means the pressure in that is more as compared to systemic. So it is getting prominent. Okay. So remember, pruned tree appearance, that is what you see in pulmonary hypertension. Next one, which is not a chest radiographic feature of left atrial enlargement. Is it double left heart border? Is it elevated left main bronchus? Is it splaying of carina? Or is it enlargement of the left atrial appendage? It is not the double left heart border. It is the double right heart border. When the left atrial enlarges, first comes the straightening of the left heart border. Then it causes the left bronchus to go up. So the carinal angle increases, elevation of left bronchus. That is what leads to splaying of carina, right? You have the enlargement of left atrial appendage, of course. And remember, now the atrium comes on the right side and it gives the double right heart border, not the double left heart border. Okay? The carinal angle increases. Okay, the carinal angle increases because the left main bronchus is elevated. The elevation of the left main bronchus on lateral X-ray, what sign does it give? You have the trachea dividing into the right and the left, and if it gets separated, what sign does it give? The walking man sign. What sign it is called as? It is called as walking man sign. So walking man sign is what you see on the lateral X-ray. Okay, correct. And if I ask you in terms of the Mogul sign, what Mogul sign do you get in left atrium enlargement? It is the third Mogul sign, right? Aorta, pulmonary artery, then comes the left atrium. So it is third Mogul sign that you see in left atrial enlargement. So look at this one, the atrium enlarging, it comes on the right side. It gives the double right heart border, not the double left heart border. Correct. Next one, classical image. What can you see here? Is this bat wing appearance? Central part mein bilateral symmetrical opacities hai. Okay, so what are you thinking of the bat wing appearance? This is pulmonary edema. Okay, this is the bat wing appearance classically seen in pulmonary edema. You can see that comparatively here, the costophrenic angles, they are spared. So it is not pleural effusion. This is bat wing appearance of pulmonary alveolar edema. Correct. Next one, egg and cup appearance. Remember the tricks from our rapid revision videos. If this is the cup and into that you are putting the egg. So what is the cup doing to the egg? Constricting the egg. So it is constrictive pericarditis. Egg in cup is constrictive pericarditis. It is getting constricted. TOF, tetralogy of Fallow. TOF gives what shape heart? Boot shape heart. Right? TGA, transposition of great arteries. What does it give? Transposition is where you are putting the egg on side or egg on string appearance. TGA is common when the mother has diabetes. Maternal diabetes, TGA is common. Egg on string, egg on side. Absolutely right. And what do you get in TAPVC? Supracardiac TAPVC. This is the heart. This is supracardiac channel. The figure of 8 appearance or the snowman appearance. Right? The figure of 8 snowman appearance is what you get in supracardiac type 1 TAPVC. Correct.